can see it.
Okay, great. So yeah, so I want to talk to you about this under-researched, under-studied condition, and some clinical aspects, and then also some translational research aspects with regards to, I think, hopefully similar to how hidradenitis has taken off in terms of research and understanding of it. Hopefully keloids will be not too far behind. For disclosures, sit on an advisory board with Pfizer, and I will talk about some treatments, and most of the treatments I will discuss are not FDA approved. I will discuss them when they are. So, yes, so our keloids, and these quote unquote exuberant scars, we don't really understand why they happen. We don't have great treatments for them, and really trying to we're talking about adding to your armamentarium with regards to treatment, then kind of trying to pique your interest in terms of research aspects behind keloid pathogenesis. So just to make sure we're all on the same page, these are exaggerated responses to wound healing. They expand X, Y, and Z planes and grow invasively into normal adjacent tissue. Besides the cosmetic aspect of it, about half of patients report pain and about 3/4 report itch. So there is significant symptomatology and it affects quality of life. Our hypertrophic scars, in the meantime, sort of grow out on the Z plane, but remain confined to the boundaries of the wound. Unlike keloids, these can spontaneously regress, so they often take months to years, and they can be symptomatic as well. Typically, itch if they do have symptoms, usually not painful. This patient has keloids on the ears, the neck, and the chest, and fits a pretty decent demographic where the highest incidence tends to occur in the teenage years and 20s, though I have seen patients with their first keloids in their 60s and 70s. There isn't a known gender bias, though we tend to see it a little bit more on women, we believe, because of the cultural norms of piercing the ears. There's an increased incidence in skin of color individuals, which I'll delve into a little bit more. And then a predilection for the upper torso. I'd say central chest is the most keloid-prone area. We see it for the ears just because of the piercings, but I think upper torso is more prone to develop a keloid per unit trauma, if you will. And then hormones also seem to play a role due to the fact there's a higher incidence during pregnancy and after puberty. We tend to think of these as arising due to trauma, surgeries, piercings, but vaccinations, cuts, we've even seen it from folliculitis, just the inflamed hair follicle is enough to trigger keloidal scars with a truncal acne. And the spontaneous keloid, the keloid arising without any antecedent trauma or inflammation is still somewhat debated in the literature. What we've come to know over the years is that there are a number of comorbidities associated with keloids. Work with my group and others have established an association with hypertension. That's probably the most well characterized. There's conflict in the literature whether there's any association with fibroids. Getting to inflammation playing a role with keloid pathogenesis. I thought that atherosclerosis and coronary stent restenosis occur more commonly in keloid patients. And then more recently, we're starting to see an association between keloids and atopic dermatitis. The fact that, for example, in collaboration with Sean Quatra at Johns Hopkins, you're able to show that patients who have atopic dermatitis are more likely to get a diagnosis of keloids within 1 year and 5 years compared to those that are not. And that those patients are, and that also applies for both Black patients and white patients with the diagnosis of atopic dermatitis. I like showing this slide. This is from Dr. Bayat's group in the UK, talking about 122 cases that had one keloid, or keloids in one anatomical site, and then another 89 cases that had a total of 369 scars on multiple sites. And really just kind of showing that for your ears and for your scalp, those are more likely to be isolated. Those are more likely to be just the only area of involvement. Whereas your torso and your extremities, those patients tend to have multiple sites involved. And so that sometimes helps triage how aggressive you're going to be in trying to treat their keloids. And so, for example, this individual here with multiple keloids on the torso, chest, shoulders, back, and I show this right dorsal wrist area to highlight that it's rare to see your keloids below the elbows and below the knees. And so when you see it below on the lower half of the extremities, forearms, shins, calves, those patients are extremely keloid prone and to be very aggressive if surgery is entertained. Tends to spare the volar area. I think this would be the closest to the antecubital fossa I've seen keloids occurring. And this is a fairly keloid prone individual. There's been some debate as to whether there really is a racial predisposition, though I think most folks, and from their experience and also in the literature, have would agree that those skin of color individuals are more likely to develop keloids than those of European ancestry. It's been reported as high as 16% in one paper, but the thought is that those of African descent about 4 to 6%, and then Caucasians as low as 0.1%. And then specifically in North America, and I've underlined these references in the OB-GYN literature, plastic surgery literature, and more recently in the derm literature, looking to show that there's a 3 to 7-fold increased incidence of keloids in Black patients versus white patients. When we do see it on white patients, we tend to see a bit more of the erythema showing through. And though you tend to get the expansive growth aspect, it doesn't tend to arise as much in that Z plane. It tends to be a bit more invasive and creeping with invasion locally, but not so much that tumoral aspect as we will see in our skin of color individuals, especially our darker skinned individuals. And I think this sort of growth aspect or invasion aspect is why I'll talk about it a little bit later. But for example, in Japan, they tend to use topical steroid impregnated tape to kind of quiet down the keloids. Whereas I think here in the US, we tend to go to injections because some of the scars we see are more tumor-like and are less likely to respond just to topicals. When we do see familial keloids, it appears in an autosomal dominant fashion with incomplete penetrance and some variable expressivity, though families tend to have the same sites, whether that's chest or suprapubic area or upper torso being involved within the family. Your familial keloid patients are more likely to have multiple sites, again, going to this sort of systemic predisposition, and are more likely to have the extremity involvement than your sporadic keloid formers. And this is just a pedigree showing the incomplete penetrance, where 11-9 doesn't have any keloids, but both daughter and granddaughter do have keloids. And then there is a differential diagnosis. The one that you should not miss would be your DFSP. And both of these, the upper one is one that came to me in my clinic with a referral for keloids. The other one's from the literature. But when you see an interesting or weird looking keloid, a good tip is to actually palpate around the scar. Typically with your keloids, what you see is what you get. And so if you're palpating around the keloid and you're finding areas with more induration than others, it's more likely to be a DFSP with its roots kind of branching out. And so recommend doing a biopsy to confirm DFSP. Occasionally we've biopsied keloids that have had purulence or slow healing erosions and ulcers, just to make sure there wasn't any underlying skin cancer. Your suppurative keloids are a thing where, similar to your hidradenitis lesions, you'll get so much inflammation that they'll drain pus. But oftentimes when you do cultures, you may get a negative or just normal skin flora with your growth. And oftentimes using treatment with oral antibiotics to be also anti-inflammatory can be helpful in those circumstances. So why should we care about keloids? This is a Turkish paper that showed that patients with keloids using the DLQI had a similar quality of life as your patients with psoriasis. And so given the myriad of treatments that we have for psoriasis, we're very much lacking, especially on the systemic aspect, to preventing or treating patients with keloids. A lot of our interventions are outside in versus inside out. I'll kind of talk on two towards the very end, pentoxifylline and dupilumab being systemic treatments. But most of our treatments for keloids are kind of one lesion at a time, outside in. And so there's very little to kind of prevent keloids from occurring in your highly prone keloid patients. These are the ones that are FDA approved or FDA indicated. I won't touch on all of these, but we'll talk on some of them before we go into a bit more on the research aspect of keloids. We mentioned these different aspects with regards to the approach to keloids. I think it's really important when talking with patients to really kind of get a sense as to what their goals of care are. Some are extremely happy just to have the itch and pain subside and to have the keloid flat, but the imprint of the scar still there. And others really want to get the best cosmetic appearance, which will typically mean a surgical intervention. And then you're kind of outlining the fact that if you end up now damaging skin that we know likes to overly heal when it's damaged, there's sort of this catch-22 in this vicious cycle. And so we need to be fairly aggressive after surgery in preventing recurrence. And then again, some of the things to do to prevent occurrence or recurrence, more so occurrence, minimizing trauma, and then for recurrence, some of the topicals, monthly steroid injections, etc. So corticosteroids are tried and true, not just decreasing collagen, but also increasing collagenase expression and decreasing inflammation. Your response rates anywhere from 50% to 100%, depending on what you read in the literature. And then you have the one focus of pain, dyspigmentation, atrophy, especially if you end up injecting deeper to the actual keloid scar. So you want to have some resistance when you're inserting your needle, and also telangiectasias. There are patients who are non-responsive to your steroids. So these are the ones who will come to clinic saying that their injections made the keloids worse, not better. And when you really kind of delve in, they'll tell you that there wasn't any initial flattening, softening, or decrease in the symptomatology, but things just continue to grow, or the needle seems to perturb the keloid even more. And again, work from Dr. Bayat's group has kind of shown that there are these non-responders may have decreased levels of the glucocorticoid receptor. And so therefore, you're therefore not, the keloid's really literally not able to detect and respond to the steroids being administered. And so you're essentially just poking the keloid with a needle and then having them come back in 4 to 6 weeks. I think in that circumstance, there are sort of two other intralesional treatments that can be employed. Your chemotherapeutics, and I tend to use 5-fluorouracil. Letting patients know there's less of a risk for atrophy and telangiectasias, but because of being a chemotherapeutic, they're more prone to getting ulceration, which will heal in with time with administration. Oftentimes, you can combine it with your steroid. So 1 part triamcinolone, and then your 9 parts 5-fluorouracil. When in doubt, realize that you would rather contaminate your 5-fluorouracil single-use vial with a little bit of triamcinolone than contaminate your multi-use triamcinolone vial with a little bit of 5-fluorouracil. So your triamcinolone first, and then you add the rest of your 5-fluorouracil. I'm not going to get into it, but the only, besides your chemotherapeutics, your bleomycin, your methotrexate, your vincristine, your 5-fluorouracil, there is some evidence for intralesional verapamil being used. I think with the thought being it may allow for a little bit more dilation of your blood vessels, a little bit trying to treating the hypoxia aspect. Maybe about as good as triamcinolone, maybe a little less effective, but for patients who don't want triamcinolone or have not responded to it, but also don't want to go down the chemotherapeutic route, you could entertain using intralesional verapamil. 2 quick tips when doing steroid or doing injections, because I end up doing a lot of injections in my clinic. Using your Loctite syringes just to decrease the chance for black splash. And if you're going to use more than 1 cc of your steroid, you're actually better off using 2 different 1 cc syringes versus putting your steroid into like a 3 cc syringe. Just using Pascal's law, the smaller the diameter of your syringe, the more pressure you can get at the tip of the needle, and so it's going to be a little bit easier to inject into the scar. One other thing, if you have a really large keloid that's extremely sensitive to touch, hypersensitive, you're not able to do your injections easily, what you can potentially do is actually do your local anesthesia as if you're doing a ring block, as if you're going to excise, and then you can inject into the scar. For all the years I've been doing it, I've had maybe one patient who developed papules at the sites of administration for the normal surrounding tissue, and she actually had a reaction to the lidocaine mixture, and so had a dermatitis, and then those insertion points had little papules. But that's the exception to going to make the rule that you can inject with a 30 gauge or 27 gauge CC around the keloid with essentially little fear of causing papules over time. I alluded to this earlier, but your fluindrenolide tape works well. I think it works better than your silicone sheets. It actually helps flatten fairly raised, slightly raised keloids, and so this is considered first line in Japan. We'll be there in a couple of weeks for the ISID. You will also potentially get post-inflammatory hypopigmentation of the normal adjacent skin, and also your skin atrophy and telangiectasias. You typically apply it for at least 12 hours a day, 5 days out the week, with your 2 days of rest. And we were talking, you can try it for your keloids up to maybe 4 to 5 millimeters in height on that Z plane before you decide that it's not really going to be effective. But for your slightly raised, very invasive keloids, it works great without having to do injections. Surgery works well, but again, you're traumatizing skin that overly heals, and so the recurrence rate is fairly high. And especially for your central chest, essentially it's going to be 100% there. And so for your really aggressive keloids or patients where they've had multiple recurrences, I work in partnership with plastic surgery and radiation oncology to do post-op radiation. The key with this is to time it so that you have your radiation done as soon after surgery, whether it's primary closure or even like a shave removal, as soon after surgery as possible. So ideally it's surgery in the morning, radiation that afternoon, and then twice the next day. It's about 16 gray over 2 to 4 fractions. And you can get some hyperpigmentation, and then longer term, a little bit of dermatitis and xerosis. There really haven't been many, if any, true cases of skin cancers arising in areas that were irradiated in the setting of keloids. I think that's always a concern, and it's brought up by radiation oncology, but there's been very little true detection of skin cancers arising in the post-radiated keloid sites. And so just case in point, this patient who had like a circumferential keloid on the left earlobe, had excision with plastic surgery, and then sent to radiation oncology. You can see very clearly the hyperpigmentation delineation, but had a very great cosmetic outcome. Two last things. I'm getting to the systemics, and then we'll get into the research aspect of things. We're familiar with pentoxifylline, typically in dermatology being used for stasis dermatitis. But there's been evidence that it actually has in vitro inhibition of proliferation and collagen synthesis. And then there was a case series in 1999 with 3 patients with large keloids being placed on pentoxifylline. The growth stopped. Keloids didn't flatten, but the growth stopped. The erythema dissipated, and their pain and pruritus got significantly better. So I've been using this in my armamentarium for your patients with multiple keloids. You're not able to get to all of the keloids with steroid injections each visit, or those where you're worried about new keloids occurring over time. Your typical dose, you can actually go BID. BID does seem to be fairly effective for these patients. And the big thing to worry about is if there is a history of bleeding, or if they're on anticoagulants, as your red blood cells are going to be flowing a little bit better due to the pentoxifylline. If their clots aren't forming well, that's going to end up being a bit of a concern. So that's the big contraindication. I'm citing a paper from a couple of years ago where we showed that pentoxifylline can decrease the recurrence rate after surgery in combination with monthly steroid injections for 6 months. After this, you're going to be on your pentoxifylline for 6 months, because usually after 6 months, if the keloid has not come back, it usually will not from that point forward. And then finally, I want to touch on dupilumab, coming from Emma Gutman-Yaski's group, and again, kind of this link between keloids and atopic dermatitis, where this index case was a patient who had atopic derm and keloid on the antecubital fossa, and which seemed to resolve and improve on both the atopic derm and the lesion on the antecubital fossa after dupilumab, and then also showing using bulk RNA-seq that Th2 signature with IL-4 receptor and IL-13 were increased in the keloid lesions versus controls. And for your IL-13, even normal skin had increased IL-13 in your keloid patients versus keloid skin and from control skin as well. I think since that point in time, there have been a few case reports and case series that have been mixed at best, some saying some improvement with symptoms, and at least with hypertrophic scars causing a decrease in size, but a couple of others did not see much improvement. I think both Mount Sinai and Beth Israel Deaconess are doing clinical trials on dupilumab in the setting of keloids. Some with atopic derm being plus or minus, and some is taking all comers with keloids. And so we look forward to seeing what those clinical trials show. This segues into the inflammation being pertinent to keloids, and that inflammation potentially even leading to the growth and the fibrosis. With the Th2 signature we talked about, but also a bit more of a Th1 and Th17. There's also evidence of JAK-STAT signaling with an increase in JAK3 in particular in your keloid lesions, and then also FOXP3 being upregulated. And so I think for this first part of the talk, keloids are exaggerated response to wound healing. We talked about intralesional triamcinolone. Silicone T-cell compression can be considered first-line modalities, but I found that with the fluoroadrenaline tape that essentially ends up being used in lieu of silicone sheets, and even for compression for earlobe keloids. And then you really should consider systemic medications for your patients with severe keloids, pentoxifylline or dupilumab at this point in time. I think what's going to be great as we move forward is that as there's more research being done on keloids and more of these reports, the thought that, for example, PDE4 inhibitors based upon pentoxifylline being a non-selective phosphodiesterase inhibitor. We've also talked about both IL-4 and IL-13, and then your JAK-STAT inhibitors, either topically or systemically being used. There's some evidence based upon Rubinstein-Taybi syndrome, where you have mutations in the CREB binding protein and EP300 having a predisposition to keloids. About 30% of patients with Rubinstein-Taybi are reported to develop keloids. And with those being both the CREB binding protein and EP300 being also functioning as histone, functioning for epigenetics, your HDAC inhibitors can potentially be used. And then there are some keloid-specific outcome measures that have been developed to aid in clinical trials. My group did recently published a CASI, Keloid Area and Severity Index, and then the group in Henry Ford has a Detroit keloid scale to be used specifically for single keloid lesions. We're sort of a mixture of a Vancouver scar scale and then a POSAS, where you've got both the patient and physician assessing size and symptoms. Let me do this. Then I'm going to segue to the second half, which can be a bit more on the research side, unless there are any questions. I'm having a hard time looking at the chat, so I don't know if there's anything in the chat. So I'm going to move forward and get a bit more on the research side. One of the when I started my residency and decided I wanted to work on keloids, all of the things that tend to make dermatology a wonderful way to do research didn't apply. One, we don't have great animal models to recapitulate keloids. Only humans develop keloids. Secondly, we don't want to biopsy keloid tissue because we may make the keloid worse, and we don't want to biopsy normal skin on those who keloid because we may induce the very thing we're having a hard time controlling. So you're either working with surgeons and during the time of surgery getting tissue. Thankfully, phlebotomy does not seem to cause many keloid scars, and so folks giving blood samples tends to be okay. And then when we do have tissue, doing explant cultures or doing xenografts can be used, but needs to say there needs to be a little bit more planning and foresight into the experiments that are done as we try to learn more about our keloids. And so my research goals, establish a registry for well-characterized subjects and families with keloids, and then really try to look at genes and gene variations that are associated with keloid formation. We talked about some of that characterization with the associations with hypertension, associations with atopic dermatitis. I'm going to get a little bit more into gene variations and trying to study some genes that may be pertinent to keloids. In terms of familial keloids, this is sort of what's in the literature, and I only want to highlight the one gene that has truly been identified so far by a group at UConn, where they looked at a Yoruba family, looking at multiple generations, and found a missense mutation in the ASAH1 gene, the N-acylsphingosine aminohydrolase gene. And then they looked in general population of patients with keloids. This population screen, and found 2 patients out of 318 also were heterozygous for this mutation. They did not find anybody who was homozygous for this mutation. They haven't gone into the mechanism by which this variant may predispose to keloid occurrence, but the gene codes for acid ceramidase, which breaks down the ceramides. And so the thought is that with ceramides playing a role in cell differentiation, proliferation, and apoptosis, that there may be aberrancy in this aspect of the cell membrane. And then in terms of more population-based with our genome-wide association studies, there's been two GWAS studies done, one in a Japanese cohort, a Chinese Han cohort, and then Shirley Russell's group at Vanderbilt has done admixture mapping for African-American patients. And essentially there have been 3 regions, chromosomes 1, 3, and 15 that have shown predisposing SNPs. One of the Japanese groups, they meant to show that at least the NED4 gene, the SNP actually was in an intron and led to differential splicing of this NED4 gene, which tends to be involved with ubiquitination of proteins. And so you get more of this transcript variant 3. And with that, this then leads to increased signaling of NED4, increased signaling of NF-kappa B and IL-6, and then going to JAK-STAT signaling. And so they're showing both in keratinocytes and in fibroblasts that if you're homozygous for the predisposing SNP, you get more of your transcript variant 3 versus those who have the normal allele. And then secondly, this SNP here on chromosome 1 has been shown to be in strong linkage with another SNP. And there's a long non-coding RNA, and this came out earlier this year, that's been called down expressed in keloids or DEEK. And so DEEK goes down in keloids, so at least it makes it easy to remember. And this leads to more collagen being expressed, more periostin, and cartilage oligomeric matrix, which are sort of these bone slash cartilage associated genes through BMP2. And so this has been looked for in Asian populations, but we haven't really looked to see if these SNPs are increased in our African American population. And so we've kind of done like an allele discrimination assay. So far, we've looked at 127 African Americans with keloids from my registry, and then compared them with age and gender matched African Americans from the Dallas Heart Study. This is a study that's been done many years ago by my postdoc mentors, Helen Hobbs and Jonathan Cohen, where they were investigating patients with heart disease, diabetes, lipid issues in the Dallas area. This is part of how they've actually identified PCSK9 as an important gene in lipid metabolism through the Dallas Heart Study. And so using those patients as controls, we're going to look to see in those different risk alleles that I alluded to, if there were any differences. A bit underpowered, been building more patients, and so we're going to redo it and even up the ante. But we were able to show that at least the risk allele associated with DEEK is also significantly increased in African Americans with keloids versus those without. And so I think as we go on and build the registry, we're going to be looking to see if any of these other SNPs are also associated with keloids in those of African descent. But secondly, doing a GWAS to then see if we can identify novel SNPs that may be distinct from the Asian cohort, and then going into mechanism-wise how this may be predisposing to or involved in keloid pathogenesis. When we're taking a look at our keloids, what's important to understand, besides the pathognomonic hyalinized collagen bundles, is that there's an increase in the dermal cellularity. So we're seeing way more fibroblasts than typical. We're seeing lots of inflammatory cells as well. We're seeing mast cells, lymphocytes, Schwann cells are present. The inflammation they're contributing to growth and fibrosis. And they're also getting this variable smooth muscle actin expression, but there's a myriad of cells all interacting. And so trying to figure out what's going on. So doing, at least at this time, bulk RNA from keloid tissue and perilesional normal tissue to really understand what's going on with keloid biology. We've done several sets of keloid tissue versus perilesional normal, looking for up and down regulated genes, and found about 344 genes differentially expressed, about 2/3 being upregulated and about 1/3 being downregulated. In terms of the genes that we found in our cohort, I want to point out the periostin that we alluded to, or collagen 5, collagen 11, your type 1 collagen, fibronectin. So a lot of the extracellular matrix genes, which is what you would expect to see upregulated in keloids. But then doing IPA pathway analysis to really look at the significance of the data and trying to find potential upstream regulators. I think what became very clear, and others have shown this as well, but that we're getting this kind of cancer-like signature with the increased cellular growth and cellular proliferation. We're also seeing, and I'm going to allude to this a little bit later on, this sort of differential expression where we're seeing lots of genes involved with skeletal and muscle development. And so we're seeing not just more keloids are sort of somewhat unique in that we're seeing more cells than usual. They're functioning more than usual when it comes to collagen deposition, but we're also seeing aberrant signaling where they're kind of differentiating into a osteoblast, chondrocyte type aspect as well. And data has been showing that the fibroblasts actually sort of have a cancer-like phenotype where they're consuming more glucose, producing more lactate. So here we're going here with your keloid fibroblasts producing more lactate over time than normal fibroblasts in culture, and then also consuming more glucose your keloid fibroblasts in the dotted line versus your normal fibroblasts as well. And so we also know that they make more collagen, proliferate more, apoptose less, and so have many of the qualities that we assign to cancer, where more proliferation, change in energetics, resisting cell death. We don't seem to have much of the genome instability. We do see angiogenesis, local invasion, and tumor-promoting inflammation. So many of the hallmarks of cancer. And kind of hitting this point home even more in terms of how important the fibroblasts are, looking at cell function, cell movement, and then the multipotency. So we wanted to identify what, if we could look in our bulk RNA-seq data and see if we can identify which what fibroblast subpopulations are critical for keloid pathogenesis. In other words, for a fibroblast, are we seeing all of the fibroblast subtypes increase in number, or is there a specific fibroblast subpopulation that is overrepresented in keloids versus normal skin? And so just orienting folks in terms of our single-cell RNA-seq and looking at the different fibroblast subpopulations. This is in normal skin. The two major fibroblast populations are your SFRP2 or DPP4 expressing fibroblasts, and your FMO1, LSP1 expressing fibroblasts. And then there are a few minor fibroblast subpopulations. Looking through our RNA-seq data to see is there a subpopulation that's increased in keloid tissue, highlighting the fact that we have increased expression of collagen 11A1 and SFRP4. We wanted to kind of see if we can incorporate that with real-time PCR. Are we seeing an increase in these genes? So looking at our data for all of the markers for our fibroblast subpopulations, the SFRP2, collagen 11A1, and SFRP4 specifically increase, and we don't see increase in any of the other fibroblast markers. Then going both to keloid tissue and normal tissue during real-time PCR, we see our upregulation of collagen 11 and our SFRP2 confirming what we're seeing on the bulk level for the expression of these genes. I think what's great to know is then looking at our gene ontology enrichment analyses, the SFRP2 gene cells are involved with BMP signaling and ECM production, whereas your collagen 11-1 fibroblasts are sort of these developmental, involved in all of these developmental organ systems. And so getting back to the differentiation and the altered differentiation of cells, these collagen 11A1 fibroblasts are the ones that are probably expressing RUNX2, SOX9, giving that sort of pluripotent like differentiation. So all of your mesoderm differentiation aspects, you see expression of those genes, with the exception of adipocytes. You don't see a fat adipocyte markers, but all of the other ones tend to be seen in your collagen 11A1 fibroblasts. And then published data in the literature, but looking at with single cell your fibroblast subpopulations, the only fibroblast subpopulation that was increased in keloid tissue was the collagen 11A1, so kind of showing symmetry between keloid fibroblasts and normal skin. The collagen 11A1 ones were the ones that are increased with a decrease in the other subtypes. And then finally, looking to see what transcription factors may be up in keloids in general, fibroblasts in particular, and how are they affecting collagen proliferation. And so going through our data, we've identified about 13 different transcription factors, period of transcription factors. I mentioned RUNX2 because this is a gene known to be critical for osteoblast differentiation. So this is likely contributing to that kind of osteoblast chondrocyte-like gene expression. But secondly, this also, at least in osteoblasts, leads to type 1 collagen expression. So it may be one of the genes that's also leading to the increased collagen that we see in keloids. So we're looking at this one in particular in the lab, and then also this random zinc finger 469. These patients, when they have mutations in ZNF469, have brittle cornea syndrome. So they have a Ehlers-Danlos type variant where they have slightly more extensible skin and joints, but their corneas are also very thin. It can actually lead to rupture of the cornea over time. And so how is this gene contributing to collagen production or other aspects of bone biology, given the fact that it's increased in keloids, but when mutated gives a extracellular matrix-like effect. So, and so in conclusion, our keloids are exuberant response to wound healing. We talked about a lot of different relevant factors with regards to risk of developing keloids, and then different treatment modalities that can be used, but then also getting into the dysregulation of cell interactions, cellular growth and proliferation, and then your particular subpopulation of fibroblasts, your SFRP2 and your collagen 11A1 expressing fibroblasts are markedly expanded within keloids and are contributing to both the function and also the altered differentiation status within keloids. Finally, I want to thank members of the lab, both current and former members, Sean Quatcher for his work on the atopic derm, worked with Shauna Lesbert at Southwestern for the work on the hypertension previously, many members of the Department of Dermatology at Southwestern, my research mentors in McDermott Center, my biostatistician, and omics analysis collaborator, and then funding sources. I thank the Derm Foundation, and I thank the NIH, and I will take any questions at this point in time. I do see one in the chat, so great question. So let me try to answer that question for Shadi. I think the short answer is I don't know. I haven't looked to see how much similarity or differences there are with that subpopulation of fibroblasts, the SFRP2 or the collagen 11A1 in other conditions. Starting to do a little bit of collaboration, potential collaboration with Heidi Jacoby, because, for example, she and Jillian Richmond and folks with UMass have kind of shown with CXCL9 and CXCL10 that the CXCL9 seems important for fibrosis, at least in mice. Your CXCL9 knockout mice don't have the fibrosis with the bleomycin model, whereas even with the CXCL10 knockouts, they do. So for morphine and scleroderma, the combination of 9 and 10 seems to be important. In my data set, CXCL9 is up for keloids, but CXCL10 is not. So there may be this aspect with CXCL10 kind of pushing things a bit more with the sclerosis versus proliferation and fibrosis. I think I'll take that question and maybe go into the literature and see how long, looking at, for example, your scleroderma or your morphia, looking at DFSPs, neurofibromas, some of those other kind of dermal proliferative conditions, your collagenomas, and looking to see what's out there, and then kind of looking to see how much similarity or differences there are in the fibroblast subpopulations. A really good question. So I think the question with Dupixent, and this was talking with the folks at Beth Israel Deaconess, I think you're going to want to start with at least the typical dose, but you actually may need to double the dose. I think they may be doing sort of double the standard dosing for keloids, similar to what you're seeing with, give me a sec, with using your TNF alpha inhibitors with hidradenitis, and you need to kind of increase the strength and or frequency compared to, let's say, psoriasis dosing. my thoughts on dupilumab, and this is just sort of my thoughts, I think we'll get an improvement with itch and pain, and you may get the growth to stop. I wouldn't expect the keloids to melt away. And I think this is from that index case report. It showed the biopsy showed fibrosis, but didn't show your classic hyalinized collagen bundles. So, I think I would give it probably for a good maybe 2 to 3 months. And if you see flattening, great. I think if you see lack of growth and any dissipation of pain or itch, I think that would be considered helpful. And then I think if you can then combine it with your other standard treatments if you're really just trying to improve the patient's quality of life. And the next question with lasers. So we're just starting to do CO2 lasers here at Southwestern in combination with steroid injections. I did my best to stay away from quote unquote cosmetics, but using the lasers at least. So I think the PDL works for the erythema and the telangiectasias. But of course, if the keloid's not red, then the PDL is not going to work. I think the CO2, doing it every 2 months, in combination with either steroid injections or topical steroids can be helpful. Probably the person who's published a lot on that would be Jill Weibel down in Miami. She's done a lot of work with lasers for keloids. But I think your CO2 or your NDI can work. And then your PDL works more so for the redness. You might get lucky with a little bit of flattening, but to try to get the keloids to significantly flatten, you're probably better off with the CO2. And then I was going to say also, I think the laser potentially works well for, let's say, your central chest or your torso keloids where you're just not wanting to, or it's not practical to excise, but you want something more than just plain steroid injections. I think getting back to the Dupixent, I think it's going to be great to see. Hopefully, we'll see what the results are with it, sort of as monotherapy. I think if you're going to do something on top of Dupixent, I would probably be more inclined to consider doing surgery while on Dupixent. And then that may hopefully help prevent the new scar from turning into a keloid. Just not sure with lasers if there's going to be any effect of Dupixent with laser treatment. I have done surgery again on patients on pentoxifylline. I don't do steroids into the wounds while they're on pentoxifylline. I've had a few 2 or 3 atrophic scars come back. And those occurred when the patient was on pentoxifylline at the time of surgery, and then we did steroid injections peri-operatively to try to decrease the likelihood of keloid occurring. So I wouldn't do that combination. I think with Dupixent, you could potentially do surgery, but I wouldn't. I think we honestly just don't know. I think I'd be a bit more inclined to do surgery on Dupixent than doing the lasers on Dupixent.
We have a question from the audience.
Sure.
Hi, Dr. Glass. This is Veronica Shi. Hopefully you can hear me. Thank you for a great talk. I just have 2 clinical questions. My first one is just about ILK. I know you had a brief comment about the max being about 80 milligrams per injection.
Yes.
Do you feel like there's any significant systemic absorption with ILK? And is there like an ultimate end point? You know, sometimes we have patients who have been doing regular injections for years and years. And so do you feel like there's an end limit for how often they should be getting ILK?
I got you. I think we typically don't. I think the dogma is that it's local, and so you shouldn't have any systemic involvement. But I've had patients who are diabetic tell me that they have to use more insulin for a couple of days after getting their steroid injections. So I do think there's probably a little bit of systemic, just not a whole lot. I think getting to your question of when to do or what the end goal is, I think once you're getting to the point where you've done maybe you're not seeing any improvement with the size of the keloids, I then start trying to space folks out. I think it's just difficult to do injection after injection after injection. What's the end goal? So if their scars are not itchy or painful, presuming that they were before, and you're now at a point where they're fairly flat, I'll go to 2 months, 3 months. I will actually have folks come back, quote unquote, as needed. I think then the use of your topical steroid tape, your fluindrenolide tape, or in a pinch, I got this from Elena Pasieska at Georgetown. You can use paper tape, your Millipore paper tape, and then just use like a clobetasol solution or other high potency steroid solution. Put a couple of drops, give it a few minutes to air dry, and it's a kind of a do-it-yourself fluindrenolide tape mimic if it's cost prohibitive. But I think for folks where you're able to do their injections and you've now gotten it flat, you kind of like, okay, now what are our new goals of care? You can start spacing out to Q2, Q3. After about Q3, I just make it as needed, and they can, if feasible, they can use your topical steroid tape. And if they still start getting itch and pain, when they start noticing a recurrence, then they can come in for another injection. But at that point, you're kind of getting it fairly early, and so you can get significant flattening again versus them waiting and then having to kind of fight the tide again. And then you mentioned as a second question. So
yeah, actually, I like that trick. My second question was just if you have tips for getting cordron tape covered, but I like that other trick.
No, I have tried appealing and they laughed at my appeal. The topical steroid tape works really. The clobetasol solution or fluocinolide solution, I think, works fairly well. A thing to take into account is some patients may put a little bit too much, and so then the tape doesn't stick because it's too wet. And so one trick a patient kind of then told me to then tell others is to kind of put the tape down with the end piece kind of hanging off a table or so, put the drops on and let it air dry for 5 or 10 minutes. And so then you have the steroid in the tape, but it's not wet, so you can get the adhesion. Yes. What I end up now doing just to make things easier for everyone as I kind of go into explicit detail about the company that makes the fluindrenolide tape in the US, you can find a coupon online that might decrease the cost to $35, and then it might decrease the cost to $150. Out of pocket, it's like $600 or $700. So I've just written folks for both the tape and the high potency topical steroid solution and given them in their patient instructions, with a dot phrase like, hey, here are options. If they cover it, great, get the fluindrenolide tape. If they don't cover it, we're not even going to try to appeal it. Like, here's the watery solution, the high potency, just get your over-the-counter paper tape and use it that way. And I think that's just minimized confusion and minimized staff having to ask about prior authorizations, and then are we going to appeal? And it's like, no, everything's handled already. We've got the plan in place, and we'll see how things go.
Thank you so much. Those are great hints for us. I understand at the VA, I think the cordron tape is covered, but at the university, we could never get it. Yeah, it's like $600 or something. It's pretty crazy.
Yes.
Go ahead.
No, so the interesting thing is for us at our county hospital, it's on formulary, right? So the VA, they can get it. At the county hospital, they can get it, but then, your typical, insurance where you're like, oh, this is wonderful insurance. Yeah, that's not, they're not covering it. Or, you got to jump through 2 different high potency creams or ointments before they'll even consider it. So it's like, let's just do this workaround instead. So.
Well, I think we've run out of time, but thank you so much for that really enlightening lecture. We do definitely want to have you out into actual San Diego so we could see your surfing skills. So we'll keep
Or lack thereof.
that in mind.